Okay, so what I would like to do is to share with you some background and clinical applications and research findings of imagery scripting, which can be best described, I think, as a transdiagnostic technique by which you can address all kinds of emotional memories. Now, the topics for this afternoon include what is imagery rescripting exactly? Why do we use imagery, and why do we use imagery scripting? We'll share with you a video example made for educational purposes. So it's a short example of the technique, and discuss different applications and share with you the main research findings about effectiveness and mechanisms of change. So what is imagery scripting? Well, in essence, the client imagines the experience of a traumatic or a negative event as if it's happening in the here and now. But this can also be not something that happened in reality, but something that has been fantasized or is sort of projected into the future. So here, the memory has a very broad meaning. It includes, for instance, the memory of nightmares or the memory of future catastrophic projections. Then the client imagines that the sequence of events changes in a desired direction. And this offers a corrective experience. And we will discuss later how this can be, how we can understand this, because it sounds a bit strange that in fantasy you can offer a corrective experience for something that was, for instance, traumatic in reality. And this corrective experience leads to a change of meaning of the memory representation. And this change of meaning can include an increase in the perception of control over the memory or its meaning. It's very important to understand, and we will also come back to that later, that imagery scripting does not involve replacing the old memory by a new fantasized meaning. In that sense, rescripting is not sort of opening a document on your computer, deleting part of the script, replacing it by a new script, and pushing the save button and getting rid of the old text. So research shows that the memory of what originally was represented in the memory is not effective. It's the emotional and interpersonal meanings and meanings related to views of the self that change. It's a very flexible technique because you can use it for all kinds of emotions and beliefs, including very complex emotions like guilt and shame. And why do we use imagery? In cognitive behavior therapy, for instance, these more complex issues are usually addressed by verbal challenging and verbal challenging of belief, for instance. So talking and using a reasoning or a verbal channel. Now, one important reason is that compared to a real experience, imagery seems to be the second best. Of course, real experiences would be better. So if a child was repeatedly abused, it would have been better if somebody stopped the abuse and intervened and helped the child to find security. However, we don't have a real-time machine, and in such circumstances, imagery is a second best option. And this is well known in other branches of psychology, for instance, in sports psychology, where imagery is used as an option to train and to focus on complex actions that top sporters have to take. A second reason is that there seems to be a direct relation between imagery and emotions. That is, if we use imagery, emotions get activated. And also the other way around, if there's activation of emotions or an emotional memory, images pop up. And this is much stronger, this relationship, than with verbal reasoning. So with verbal thinking and reasoning, people can sort of take a distance from the emotions, much more than is possible with imagery. And lastly, imagery activates the brain almost similar to a real experience. And this is very fascinating. It shows how powerful our human imagery capacities are, that we can activate our brain almost as if a real experience takes place, although we know we're not hallucinating and we know we imagine. And these research findings, it's not from clinical psychology, it's from fundamental psychology, illustrate this. This is fMRI scans from people that lie in the scanner and either saw an object projected on the screen in the scanner, and here you see the activation. If it's orange and red and yellow, it means activation. If it's blue, it's reduced activation. And you can compare it to the situation where the participants imagined seeing the same object, so did not see it in reality. And at the right column, you see the difference between really perceiving something, imagining it, and you see there's no colors here, so no meaningful difference between imagining something and seeing something in reality. And this holds for the more frontal parts of the brain. Here, the green lines show you the slices that were scanned of the brain. This is the midbrain area, important for memory and for emotions. And here again, you see very similar activation patterns and no important differences between the two. The differences start to pop up, however, at the backside of the brain, especially where the more primary sensory areas of the cortex are placed. And this is understandable because there is no real sensory input when we imagine something. Nevertheless, still at the back parts of the brain, there's activation. Okay, so this sort of demonstrates how powerful our human capacity is to imagine. And it might explain why the use of imagery is so helpful when we apply it in a clinical context. It might also underlie why we describe imagery scripting as an experiential technique. So it's not so much about reasoning, it's more about experiencing in fantasy a new experience that offers new information. And because of the full activation, almost full activation in the brain, we think that the experience is sort of more directly fed into the existing memory representation. And as clinicians, you might be familiar with patients who, when you apply cognitive techniques, say, I know it. For instance, I know I'm not guilty, but I feel guilty. And with the use of imagery scripting, we think that this sort of difference between this dissociation between knowing and feeling is reduced. Another reason to use imagery scripting as an experiential technique is that you, in fantasy, return, if you wish, to the time or the developmental level when the original experience was encoded. So for childhood memories, the patient, although an adult, experiences the corrective information that is offered at the child level. It also means that non-verbal systems are activated and are involved. For instance, the attachment system is activated, and that's very important in early trauma and in personality disorders, etc. So it's not a verbal technique, it's a technique that involves as many systems as possible. As I said, it's a very flexible technique, so a client and therapist can work with almost anything that comes up at the moment. New emotions that come up, or new beliefs or thoughts that come up, can all be addressed. So important aspects of imagery scripting should be mentioned. It's not a training here. I'm just presenting the technique and the research findings, but I want to share with you some important elements of the protocol that we developed and tested in controlled clinical trials. And we cycle in this protocol. We help the patients, I must say, cycle through the following aspects. We start with the sensory experiences. So we ask patients, what do you see? What do you feel in the body? What do you hear? What do you smell? What do you taste? Whatever. Then we go to the emotions. What do you feel emotionally? We ask them. And where do you feel this in your body? Can you focus on that? And then we go to cognitions. What are you thinking now, or what is going through your mind? And then we focus on emotional needs. What do you need now? And these cycle of questions repeatedly asked in between the actions of that take place in the rescripting. So they inform the person who is doing the rescripting, the therapist, and later in therapy, the patient, him or herself. I will come to that in a minute. They inform the person who's rescripting what is taking place in the mind and the emotional processes in the patient, and what are the needs that are that need to be met. A second important aspect that we learn through research is that the emotional memory should be activated as much as possible. So there should be real emotions. And rescripting should start at the hotspot representing the most difficult moments of the memory. And this most difficult moment should be clarified in collaboration with the patient. We found with research that if we start rescripting too early, it's less effective than when it is connected to this most difficult moment. What we also learned is that it helps to correct dysfunctional attributions. It helps to actively tell the patient in the rescripting that what happened to them is not their fault. So if a child is abused or rejected or neglected, we actively tell the child that it's not that it's not their fault, and they should not feel guilty or ashamed. The perpetrator should feel ashamed. And even when the patients don't ask for that, they report, it helps them to experience this corrective information. Another thing that is not always there in practical applications is that following the ending of the immediate threat, if there is a threatening experience, you should take time to address further needs. And these further needs might be related to deeper levels of the trauma representation. So let's focus for a moment again at children. And when they experience traumatic abuse, for instance, usually this takes place in a context that is not safe as a whole. So if it would have been safe, either the trauma would not have happened, or the child would have been helped with processing it. So there are elements in this more complex context that are a barrier for finding safety to process the trauma. And these further needs that are related to that, for instance, the need for feeling safe for the future, or feeling safe to express emotional needs, these further needs should be addressed in further actions in the rescripting. And lastly, research shows that using imagery scripting leads to better positive effects if it ends with imagining an emotional positive activity. So in our trainings, we train therapists to help the patient imagining a positive activity at the end of the rescripting. Now, there is some, especially in Germany, hot debates again about the risk of trauma-focused therapies to induce false memories. And because of maybe the label imagery scripting, people are not specialists in this field, think that imagery scripting leads to false memories. Actually, we have quite some research showing that if you follow the protocol, that's not the case. It's very unlikely it will induce false memories. But there is one main guideline for that for you clinicians, and that is don't suggest factual details that are not in the story of the patient during the memory activation phase. You can do whatever you want during the rescripting phase because patients know that the rescripting is fantasy and they have to do their best. It demands cognitive effort to do the imagery work, so they know this is the fantasy part. They don't ascribe that to the reality. But during the memory activation phase, you don't want to tell the child, for instance, that the perpetrator had a green shirt if the patient doesn't tell anything about the color of the shirt. So don't suggest factual details, prevent false memories in that way. Okay, we have a number of applications now documented in, especially in small and larger scale studies. And that includes processing all kinds of traumas and other negative experiences, including nightmares and negative future expectations. But we can also offer correction of experienced emotional deprivation, which is much more difficult with techniques like imaginal exposure, which is essentially breaking through the phobia of negative traumatic memories, and EMDR. So because we can offer emotional care and attention to further needs of the person or the child, we can address emotional deprivation. Imagery scripting, as I said, is suitable for all kinds of emotions, including the complex emotions like guilt, shame, and anger. And this is a list, not complete, of all kinds of disorders where it has been applied to, of course, post-traumatic stress disorder, PTSD, but also depression, social anxiety, OCD, body dysmorphic disorder, eating disorders, personality disorders, where it's, for instance, an part of Schema Therapy, but also psychosis is a new study showing it can be effective for processing traumatic experiences in people who suffer from psychotic disorders, and especially hearing voices, complicated grief, etc. Now we are going to have a look at an example, and this example shows you the early phases of therapy where the therapist does the rescripting with a patient. It's all role played, so it's educational video for training purposes with a patient who suffers from memories of a very, at least verbally, but also physically aggressive father.
Okay, so I just want you to close your eyes and I want you to get an image of that memory that you spoke about when Dad lost it at you for dropping the drink in the car. And you're in your room and he's taken off and he said, I'm going to come back and teach you nice. And yeah, just to bring it to mind, what do you see? Try to be that little 6-year-old girl.
Just sitting on the end of my bed.
Yeah.
Got some toys. Just not playing. I'm just sitting there looking at the door.
Yeah.
Just waiting for him to come through the door.
Yeah. Okay. And how are you feeling?
I just feel really scared,
Yeah.
sad,
Yeah.
alone.
Yeah. Yeah. You feel it in your body?
Yeah.
Okay. And what's running through your mind?
He's going to come in, he's going to yell, he's going to just be so loud, and he yells for hours. He's always so angry.
Okay. So just let this image play forward into the point where he's coming into the room, yeah, and he's being horrible. What do you see?
Just him big and red and loud, and just all I can hear is, you're always doing stupid things. It's all your fault. You do everything wrong. I'm gonna have to fix it again.
Pause the image. Okay. And I want you to bring me into the image. Okay, me now. Okay, and I'm there, and I'm standing between you and little Nikki. And maybe, do you feel like you might want me to be bigger in size? Like, can you imagine? Yeah, would that help? Okay,
yeah.
So you can make me bigger, so I'm sort of taking up a lot of the room, and a lot taller than him, and a lot bigger than him, yeah? Okay. And I'm there in front of you, and I'm going to speak to your dad, and I'm going to say, you are going to stop right there. I am there to protect little Nikki, and I'm not going to let you have a say anymore. The game is up. We are running the show, and you are not. What is wrong with you? I'm never going to let you harm little Nikki ever again. How's he responding?
Just really angry. He's really angry at you now. He's just yelling at you as well.
Okay, and I'm going to say, you can stop right there. You can stop right away. I'm not interested in you being angry with me. I am interested in Nikki, and I'm never going to let you have a say. And in my right hand, I have a pager for the 2 police cars that are outside. Okay? How's he responding?
He looks angry.
Yeah.
Angry and worried.
Okay, and what do you need? Do you want me to bring the police into the image? Okay, so can you see me? I'm pressing the button. Okay, the page for the police outside. And the police are coming in and storming the building. Yeah?
Yeah.
Yeah? Okay. And what do you see?
The dad's being angry with them, shouting.
Yeah, and how are they responding to him?
They're putting him in handcuffs.
Yeah, okay.
Pulling on him.
Yeah, okay. And I'm going to say, Dad, you've met your match. You are not going to have a say anymore. You are not going to hurt little Nikki anymore. The police are taking care of you. And what are the police doing?
They're dragging him out.
Yeah, okay. How are you feeling when that's happening?
I feel good.
Yeah?
Yeah.
Yeah? Great, okay. So what happens next? Can you see what happens next?
They're gone.
Yeah?
Doors.
Yeah?
Doors open, but they're gone now.
Yeah, okay. So he's gone. The police have taken him away. Okay, and how are you feeling?
Less shaky.
Yeah.
Not scared.
Yeah, okay.
Okay, so this video is a short demonstration of the technique, and it says it uses fantasy in the sense that in fantasy the therapist grew in size, became much larger than this father to help create safety, and also the therapist was able to call in the police immediately, which is also sort of fantasy aspect. Now, this is very fascinating that we can use these sort of fantasy elements, and some patients also love to use magic powers, but that depends on the patient. So the whole technique is not so much focusing on what is realistic, but more what does the job. As long as the patient feels safe and taken care of, it works. And if you try out something and it doesn't seem to work, just try out something else until it works for the patient. That's the general recommendation. So fascinating technique in that sense, not rational, but very powerful through these images. The other thing I wanted to say is that after this initial stage where the therapist stopped the abuse by the father and the father was taken away by the police, you continue to ask for further needs of the child. And there might be further needs. For instance, the child might feel that it is still not safe at home and wants to live with a family where it's much safer. And there it might want to be comforted and soothed, and there might come sadness about what happens all the time. And then you want to end the rescripting with the child, for instance, having fun playing with a friend at the other family or eating pancakes, so some positive ending. Now, the question arises, of course, what memories should we use for this technique? How to find a memory or an image? And we have several ways. Well, first of all, of course, we have clients who bring in memories or images. So if somebody comes in with a post-traumatic stress disorder, and there are usually intrusions or nightmares, and the patient can tell you these are the memories of what's happened, and it's clear what to address. Although the number of memories with repeated abuse, for instance, might be too many to address them all. That doesn't matter in the sense that they're usually linked in sort of networks, and addressing one memory successfully will lead to a spread of to other memories. So the themes or the issues related to one memory, when successfully addressed, will spread to other memories. So that's the more easy type, if you wish. More difficult are the patients that don't report direct what the memories are that are underlying their problems, yet you know there must be early experiences. And then you can use an affect bridge technique, which is an associative technique. The client imagines then a recent negative experience. So the client closes the eyes and imagines something negative that happened, for instance, yesterday, as if it happens in the here and now. Then you instruct the client to stay with the negative emotion and let the image go. And then the client waits for a childhood image coming up. You instruct the patient, okay, see and wait whether a memory from your childhood comes up. And then you use that memory for rescripting. And the assumption is that that underlies the present sensitivity for specific triggers. And second issue is who rescripts. You saw the video example of the therapist rescripting. And with childhood trauma and negative memories, our standard protocol now is that in the start of treatment, the therapist does the rescripting, and in the end of treatment, the client does the rescripting, the client from their present adult healthy perspective. So in start of treatment, let's say we have 12 sessions, which is sort of standard for PTSD treatment now. We have 12 sessions. The first 6 sessions, the protocol says the therapist does the rescripting. The last 6 sessions, the client does the rescripting. And we know now from feedback through qualitative studies we did that both are useful. At the start of treatment, the therapist offers a model how to rescript, offers healthy attitudes, insights, and the necessary behaviors. And in the second half of treatment, the client sort of learns to stand up for their own vulnerable child, if you wish, which leads to a feeling of empowerment. And the client also learns to take care of the more vulnerable feelings, which is important to become independent of treatment. Now, if we have traumas from adulthood or negative memories in general, and not so much with roots in childhood. We can use the same technique as with childhood memories, but here it's not a child in the memory, it's the former self. Or the client imagines to not change perspectives, but to act differently at the most difficult moment. And this is more useful for relatively recent images. Recent traumas or negative experiences. So let's say somebody had a negative experience a year ago, then you might use that second option. Now let's discuss a bit the effectiveness of the imagery scripting. And this slide shows you the dose-effect relationship from studies that were included in the meta-analysis in 2017. And it shows you that with one session of imagery scripting, you have an average effect size of about 1, so that's already a very large effect. A change from pre to post treatment. So one session already has on the average a large effect, and that effect rose with increasing number of sessions. And the maximum that was found in these studies was 16 sessions, where in general you have about an effect size of Cohen's d2, a very large effect. What do we know about, more specifically about PTSD treatments? I will discuss a number of treatment studies. The first one is the IRAM study, an international study where imagery scripting and eye movement desensitization reprocessing, EMDR, were compared as treatments for post-traumatic stress disorder related to childhood trauma. Of both treatments, a maximum of 12 sessions were offered, and both treatments were found to be extremely tolerable with less than 8% treatment dropout. So very tolerable, acceptable treatments for a very severe disorder, and both have very good effects. Here you see the development on the CAPS, that's the severity of post-traumatic stress disorder symptoms. During wait time, there is little change, a little bit of reduction, but not significant. Then with treatment, there's reduction, and we decided that the essential moment of comparison of the two treatments would be at 8 weeks follow-up, because the CAPS asked for the PTSD symptoms during the last month, and that would overlap with, on average, the half of the treatment. So the 12 sessions were offered in 6 to 8 weeks. And at 8-week follow-up, you see there's no real difference between the two treatments. However, the lines seem to cross here, and that gets clearer with the effect sizes. So these are pre to post effect sizes, and what you see here is that, although not significantly, EMDR in the short term seems to have a bit larger effect size. Then at 8 weeks follow-up, there's no notable difference. And then at 1 year follow-up, there's a crossing. So there is a tendency for imagery scripting to have larger effect sizes than EMDR. And when you look at the recovery rates, it's 68% at 8-week follow-up and 81% at 1 year follow-up. So there's a further improvement also in recovery rates, extreme high recovery rates for both treatments. And you see similar patterns when you look at other secondary outcomes like guilt, feelings about all traumas. You see here that again, there is this sort of crossing in the effect sizes in the long term tend to be higher for imagery scripting and half-a treatment. So the short-term effects seem to be a bit stronger in EMDR. Now, perhaps more importantly, is the finding that there is a difference between the two treatments in their effectiveness depending on the presence or absence of major depression or any depressive disorder. and 63% had a comorbid major depression. So almost 2/3 of the sample is also suffering from a clinical depression. What you see is that with this comorbid depression, in the longer term, imagery scripting had better effects than EMDR. It's not an immediate effect, it grows with time. Very interesting. Without further treatment, you get this further improvement with imagery scripting. And the opposite is taking place when there is no comorbid depression. That is, imagery scripting does a better job when there is only PTSD and no depression. Now, we have some ideas about explanations for the presence of comorbid depression. It's more difficult to explain the effects with the situation with patients where there is no comorbid depression. This might be a chance finding, although the significance levels are very strong. So we will test this again in the current study that is almost completed, and see whether we can replicate the findings. And that would really be helpful to come to a better indication for treatment. Here you see at 1 year the effect sizes, and you see that with no comorbid major depression, EMDR is almost twice as effective as imagery scripting, whereas with comorbid depression, imagery scripting is twice as effective as EMDR. So we could easily double the effectiveness of treatments if this is again found in the current study by giving people with comorbid depression imagery scripting and without EMDR. Now, this study tested the treatment of PTSD when it was comorbid with substance use disorders. And these patients were referred to a substance use disorder clinic. So the primary goal of the treatment is to treat these patients for substance use disorders, mainly alcohol, but it can also be all kinds of drugs. It is known from research that if you don't treat the comorbid PTSD, there is a very high chance of relapse. So it's actually important to address both disorders. And in this study, one of the questions was, what is better, to do the treatment in parallel, in PTSD treatment in parallel of substance use disorder treatment, or sequential, first substance use disorder treatment and then the PTSD treatment. Now, it doesn't make a difference, and so you can easily, and that's sort of, requested by most patients, do it in parallel instead of first one and then the other disorder treated. So the substance use disorder was treated with standard CBT protocols for that, and the PTSD treatment was either provided parallel or sequential after the substance use disorder. And the PTSD treatments that were studied were prolonged exposure, EMDR, or imagery scripting. More than 200 patients participated. And the first interesting thing is that when we asked patients before the start of treatment what treatment they would prefer, most of them said, I want EMDR, which is very popular and very well known in the Netherlands. Then prolonged exposure or no preference, and imagery scripting was the least popular. It's not very well known in the Netherlands, so that might be an explanation. But then when we look at the treatment retention, so these people were randomized, so we asked for the preference, but the preference was not followed. And then we see that the dropout from imagery scripting was significantly less than from EMDR and from imaginal exposure. So here we see that imagery scripting is much better tolerable, acceptable for these patients, despite that they initially found it a strange treatment. And then the effect sizes, They were very good, again, for in the short term, and this is so immediately after treatment for imagery scripting compared to the other treatments. Still another study investigated whether for the treatment of post-traumatic stress disorder, it's helpful if there's comorbid personality disorders, cluster C personality disorder, whether it's indicated to add during the trauma processing phase group schema therapy. And in short, the answer is no. If you see the development on the PTSD complaints, symptoms on the CAPS, you see a deep decrease with only imagery scripting, which is very much in parallel to the combined treatment of imagery scripting and group schema therapy. Now keep in mind, these patients had a primary diagnosis and a request for help for the PTSD. So there was no clear request for help for the personality disorder problems. So the take-home message of this is, if there is clear PTSD and there's a request for help for PTSD treatment, you can better treat the PTSD first, even if there's comorbid personality disorders, and see whether there might be a further request for personality disorder treatment or not. And the chances are big there's no further request for that. How about depression? Well, depression has also been an area of research now, and it's very important that we study this because of the higher relapse rates after initially successful depression treatment. This is a study from Hong Kong where cognitive restructuring in 3 sessions was compared to 3 sessions of imagery scripting. And what you see here is that initially there is only a tendency, a trend, there's no significant difference, but at a 2 months follow-up, there's a very powerful difference between cognitive restructuring, the dotted line, compared to imagery scripting on the BDI, the back depression inventory. Effect sizes are very strong again for imagery scripting. And you see the same pattern in that study, this Hong Kong study, for intrusive imagery, more reduction with imagery scripting, rumination. Also, again, this further improvement without further treatment, worry, and experiential avoidance. A recently published German study with inpatient treatment for a moderate to severe depression demonstrated that imagery scripting, here combined with cognitive restructuring, had superior effects compared to the usual treatment there, which is problem solving. So during this inpatient treatment, the usual treatment is problem solving, but the data show it's better to use to offer cognitive restructuring combined with imagery scripting. And the same holds for another outcome measure, and this was very interesting, I think. This was physical activity during the inpatient stay. The number of steps people did per day, and it is a sort of index of whether the depression leads to inactivity, or whether it, when you treat the depression, whether it leads to an improvement in physical activity. And you see, again, a very strong effect in favor of the combined cognitive restructuring and imagery scripting treatment compared to treatment as usual, more activation. Still another study tested, it's a pilot study, a feasibility trial, imagery scripting and a memory specificity training combined with supportive therapy in depressed adolescents. And 4 sessions of the 2 treatments were offered at school. And you see, again, very nice effect sizes. Here there are controlled effect sizes, so it's the difference between imagery scripting and memory specificity training in favor of the imagery scripting treatment compared to the supportive treatment. Then OCD, and this treatment was a case series study of 12 cases of treatment-resistant OCD cases. 11 of them had previous cognitive behavioral therapy, mainly exposure with response prevention. And all of these cases, interestingly, could identify a memory related to the start of the obsessive compulsive disorder. And that memory was taken to Rescript. And it was preceded by a control session where they talked about the memory. So there was attention to the memory with no active treatment. There was only one session of imagery scripting, and that led to an improvement on the Y-box with a very large effect size of 1.9. So here you see from baseline to talking, no real change. Then there is this massive change already after one session of imagery scripting, which further progresses up to including a 3-month follow-up. Social anxiety disorder is another disorder that researchers get interested in to apply imagery scripting to. And this is a study from Korea where they assessed the effects of one imagery interview and 2 cognitive restructuring combined with imagery scripting sessions to 3 supportive sessions. And what you see is that all these indexes of images, image vividness, distress, memory distress, and encapsulated beliefs reduced more with imagery scripting than with control. And the fear of negative evaluation and the Liebowitz social anxiety scale, they all reduce more with imagery scripting than with the control condition. And there are many studies now that use the fear of negative evaluation as an outcome measure. So we can have a look at the dose-effect relationship again. And what you see here is that with one session, again, you see this one session effect of Cohen's D in the effect size of 1, which is already a large effect, which increases to 2 when on average 9.5 sessions were offered. So again, a dose-effect relationship between imagery scripting number of sessions and the effectiveness on an index of social anxiety. And lastly, I want to share findings in psychosis, because this is something that is sort of avoided by therapists to apply trauma processing techniques. And this study was a pilot study, a multiple baseline case study where voice hearers, all with a diagnosis of psychosis, were offered imagery scripting. Now, people with hearing voices often have traumatic experiences, and often the voice they hear is in content or in quality related to the perpetrator. So there is a sort of thematic or associative relationship between the voice and the trauma. And this study was run by Georgie Powlick-White in Australia, and she offered 8 sessions, only 8 sessions of imagery scripting. The limited number has to do with their insurance policy, so they are not allowed to offer more than 10 or 12 sessions, so they needed some preparation sessions. Of the 12 participants, there was one dropout, again, a very low number, so a very acceptable treatment. And in this sample, a PTSD diagnosis was not required. Some of them had it, but not all. And if you look at the trauma intrusions, you see a massive reduction during treatment, which was maintained up to including a follow-up at 22 weeks. So very effective when you look at the trauma intrusions frequency. And then the voice frequency also reduced, but not as massive as the intrusions. So you see that there is a tendency that the voice remains, but although there's reduction. However, the voice distress related reduces with a good effect size, and also the post-traumatic stress symptoms reduce. You see this here, and you see also that the RATS severity ratings, all the auditory hallucinations severity reduces also with a high effect size. Probably even better effects would be reached if they could offer more sessions, but that was not allowed. So many studies have been done now, so let's have a look at recent meta-analysis that summarize, that pull the effects over studies. And this meta-analysis looked at pre-post effect sizes, so the changes, and we see an average effect size of 1.09, which is a strong effect. And as I said, many of these studies had a very limited number of sessions. And when we look at the effect sizes when imagery scripting is compared to a passive control condition like waitlist or just attention, just talking, then you see still a high effect size of about 1 of the difference between imagery scripting and that control condition. However, when the immediate effects pre to post are compared between imagery scripting and active other treatments, then we see an effect size of almost 0. So it means that there is, in the short term, no clear difference between imagery scripting and other active treatments. However, as you saw in some of the slides I shared, in some of the figures, imagery scripting tends to have additional effects in the longer term. So what we need is really a meta-analysis of the longer term effects. Then let's have a look at the mechanism of change, because that informs us about what is underlying this. This sort of fantasy, this sort of strange technique, maybe. And this was done in the PTSD treatment study, where imagery scripting was compared to EMDR, the study. And at each assessment there, participants did a little assessment by imagining their most important trauma and then rating how vivid the image was, how much distress they experienced, and how much they believed in the ideas, in the beliefs that were sort of activated when imagining the trauma. And we used so-called Granger causality tests on person-centered data. That is a bit technical now. What I mean in this is that we start with every individual patient as the unit of research. We look at changes within the person, and we test whether a change in, for instance, the strength of the belief precedes changes in PTSD symptoms, or whether it goes in the other way around, whether there's first change in symptoms and then followed by change in beliefs. And what we found was that with imagery scripting, when you pull all these findings over all participants, we see significant effects for a change in encapsulated beliefs and in distress preceding the change in the caps in the PTSD severity in imagery scripting. And that is what we hypothesized, because as I said, the theory says imagery scripting works primarily through a change of meaning and emotional meaning of the trauma representation, of the memory representation. And in EMDR, in contradicting the hypothesis, we didn't find any evidence for a mechanism. And we expected that the change in vividness would precede the changes in PTSD symptoms in EMDR. So this is a bit of a puzzle, because lab studies find that the change in vividness is very central to the mechanism of EMDR. So maybe our assessments were not frequent enough, and we missed the assessment of a change that took place before we did an assessment. So to wrap up, I shared with you the ideas underlying imagery rescripting, and I shared with you research findings. And let me then summarize what I think are the potentials of imagery rescripting, the potentials to use it in clinical practice. Well, for instance, there's this very high acceptability and low dropout rates, and it is a safe technique. So, although patients might find it initially very strange, they might say, well, how can fantasize something that should have happened but did not happen in reality help me? And we have now a lot of research data demonstrating that it's actually helpful, and that the mechanism is not something like replacing the old memory by a fantasized memory, but that fantasizing what was needed but was not happening in reality helps to set in movement emotional cognitive processes that lead to a change of the implications of what happened. So the views and the feelings about the self or other people or the world in general start to change. It's a transdiagnostic technique, so you can use it for all kinds of diagnoses and problems. And I shared with you findings that one or a few sessions already can have effects. You can also consider it in case of treatment resistance. So you apply a recommended technique, like for instance, a study in OCD demonstrated it doesn't work. Maybe consider to go back to a memory or that of what happened when the OCD started, and use imagery rescripting to address that memory. That can take away a sort of emotional block of profiting from your usual treatment. Imagery rescripting is quite easy to train in large groups, and all these studies have been based on therapists having a 1 or 2 day training in imagery rescripting, or just reading the technique and trying it out themselves. Imagery rescripting can be easily integrated in many psychological treatments. It has been taken away from Gestalt therapy and integrated in CBT and in Schema Therapy. In Germany, it's integrated in specific types of psychodynamic treatment. So it's really a technique that can be used in different approaches. So we think that imagery rescripting, by focusing on the underlying emotional memories, addresses these underlying mental representations. And if that's indeed the case, the reasoning is that it should lead to less relapse than many CBT treatments. We know with CBT, for instance, when you look at depression or interpersonal psychotherapy, that there is 50% relapse within 2 years in those that initially respond clearly to the treatment. So they are depression-free, yet in 2 years there's a 50% relapse. So there's so much room for improvement. And one of the reasons might be that the underlying vulnerability is not addressed. CBT and IBT, the standard protocols, are really focusing on how to get people out of the depression, for instance, by activation, or by addressing their current conflicts with other people, or by correcting negative thinking. And there are research indicators for this. We know that there is a very important predictor of the chance of relapse, and that is childhood trauma. The more childhood trauma, the more adverse, the more negative experiences in childhood reported by patients, the higher chances that there will be relapse after an initial successful treatment, pharmacological or by CBT or IPT. Okay, that's it for me for sharing these ideas and research findings. Thank you very much for your attention. And here are two websites where you can find your way if you want to book for a training. Thank you very much.